Individual variations in drug response. This entire lecture series is going to help to kind of point out some of our greatest differences and our greatest similarities. So I hope you guys really enjoy it. Our first set of learning outcomes here, again, follow along throughout the lecture series. You'll see the icons appear on different slides to help you connect your learning outcomes and the stuff that we're talking about. A holistic approach. When we think about pharmacotherapy, I bet you probably didn't get up thinking to yourself, look, I just need to give this chick this drug and get on with my life so that she feels better, I feel better, and we're all together. Healthcare really isn't about that anymore. Healthcare is about making sure that our patients get the absolute best care in the way possible for them so that they'll actually be compliant and lead a healthier, better life. So really understanding the entire total picture of a patient, and when we talk about pharmacotherapy, it really does help. So our Western medicine standpoint right now, we're really practicing like you have a disease, the disease needs a pill, here's your pill, and we move on. We really need to kind of back up and say to ourselves, what is this patient eating? What about their environment at home? What about their financial situation? It's understanding the total picture of this patient that's ultimately going to get them on a better path to wellness. So super important that as we're thinking about these patients, that we're not just taking in like this little snapshot of what we do in the hospital or what we do in the clinic or what we're doing in the community. We need to understand the entire picture. You need to understand who 3P is. 3P is the dog, and the reason why the dog is important because if everything ever happened to the dog, the patient would just shut down. So it's important to understand everything about your patient, not just this is the pill for this disease. It's understanding cognitively how they think about it, from a social aspect, how they think about it, from a heart standpoint, how they think about it. So these psychosocial factors that we're going to be talking about, it's really important for us to pursue our patients' compliance with medication and a positive action. We need to really upsell the medications and the therapies that we're going to do for the patient. So here's what I mean by that. We need to be like, oh, Miss Jones, let me tell you something. I can make you feel so much better if you will take your medications like the doctor prescribed. This medication that we're going to give you today, it is so good. Let me tell you, it does this and it does this, and it's going to make this happen. It's going to make this happen. We're upselling the medication. So what happens is that now that patient processes through all that, and when next time she sees that pill sitting in there, she's like, oh my gosh, this medicine's so good for me. And so by upselling this medication, we provide a positive that the treatment is good, therefore we will have a good benefit. If we go in there and we're like, listen, this medicine I'm fixing to give you, it's going to make you nauseated, it's going to make your poop turn green, it's going to make all these horrible things happen to you. How quickly do you think that that patient is going to pick up that medicine? If the treatment is bad, they're going to get no benefit from it. So really need to upplay the treatment. So there are things that I don't like to do. I bet there are things that you don't like to do. Okay, I really have a hard time eating fruits and vegetables. It's not that I don't like the taste of them. I like the taste. I do. Once I eat them, I'm good. But I think it's just getting it into my head that I've got to do this like for lunch and I need to do this for dinner, right? Well, lunch is probably the worst. I do okay on dinner. But you see, I have to convince myself that fruits and vegetables are good and that they're going to taste right and that everything's going to happen. You have to do the same thing to your patients. Again, we have to have this conversation that the problems are manageable and that the treatment that that we're going to do for them is going to make them feel better, not make them feel worse. Okay, that's basically in a nutshell what that really means. So there is a difference between culture and ethnicity. I want you to use your book and I want you to define these out because you're going to need them. But in a nutshell, ethnicity is the thing that kind of like makes up your DNA. Like if you were to do ancestry.com, it would tell me exactly where you came from. versus your culture, which kind of tells me these are the rules and the practices and the things that I'm most ascribed to in my household. When we say that someone is culturally competent, what we mean by that is that that person recognizes the influence of culture in someone's life. Okay, so I have a friend of mine that's a nurse, and he was really into Vietnamese culture, and I didn't quite understand why, but I'll tell you that he ate Vietnamese food most of the time. It was just not something, it wasn't his ethnicity, but it was something that he kind of ascribed to. So understanding how his culture influences his life can affect the way that I need to do pharmacotherapy with this patient, okay? And understanding that his diet really could play an issue in the way that the medicines that he's being prescribed could be absorbed, metabolized, everything, distributed, excreted, the whole 9 yards, the whole form of pharmacokinetic gamut. So understanding how their culture affects their lives. In the state of Texas, we very much have what we call a Tex-Mex culture. So in that Tex-Mex culture reality, you know, a lot of us are consuming a lot of Mexican food, which is good, except that it's high in carbs, right? You think about the rice, the beans, the tortillas, the chips, okay? We have a very high loaded carbohydrate diet because we're Texan. So again, understanding how my culture influences my dietary. The other thing we need to do is that with our patients of different cultures, or just really patients in general, we need to respect their alternative therapies. One of my favorite alternative therapies that I do quite frequently for myself, for my kids, whatever, I do essential oils. Okay, I know evidence-based practice says that there may be absolutely nothing to that. However, what do I do with essential oils? Well, when my kids are sick, I put the eucalyptus in the pot and we aerate it through the house. Whenever someone else is sick, I may put thieves in there to help kind of keep the, the bacteria down. So there's some evidence-based practice in that, there's some not. But I use them. I like the way they smell, I like the way they make me feel, so I go with it. So the way I look at alternative therapies is, if it don't hurt, leave it alone. If it works for the patient and it makes them feel better and you're getting a positive therapeutic benefit from it, then we continue on that. I also try to help my patients understand that these two alternative therapies and the pharmacotherapy that I'm ordering for them, they may go hand in hand. There's a lot of doctors out there right now that when a patient develops diabetes, they'll encourage them to go to Walmart, Walgreens, their favorite pharmacy, and to purchase something called cinnamon capsules. And that is what an adjunct therapy that they use in conjunction with their metformin. So my responsibility as a provider who's writing medicines is to make sure that I have established a relationship with the patient where they feel like they can share with me what they're doing in order to treat their disease process that maybe is quote unquote off the books, okay? And to be open and understanding and not to be like, oh, what are you doing? Why? And not to be very judgmental about it because I want that patient to continue to share it with me. Again, sometimes beliefs about health and disease play a big part in what we're doing as far as pharmacological therapy. I deal a lot right now with a lot of African Americans of very low income. One of the barriers that I have to overcome is that I have to get them to understand how blood pressure and diabetes lead to long-term complications. So sometimes one of the things that I have to do is I have to say, do you know anyone on dialysis? And they can generally tell me yes. And then I'll say, well, how do you think they got there? And I kind of use that understanding in order to establish why I think that today treating your blood sugar that may be only 200 or a blood pressure of 130 over 90 is important today because I want to avoid long-term consequences later. So I have to understand what their belief system is about the disease and about what's making them sick. Okay, so I want to take you through a little case study action here. We're going to call this Miss Ethel. I love Miss Ethel and she's adorable. Have no fear. This is not a real patient photo. This is photo stock off of Google. And Miss Ethel was being discharged home today. She had a stroke and now she's experiencing some weakness on this left-hand side. She was using a cane prior to her admission, but today we're going to send her home with a wheelchair to get around in her environment. As of right now, and I'm telling you, we're sending her home, do you have any concerns about sending sweet little Miss Ethel home? Okay, all right, next slide. What if I told you that this is Miss Ethel's home? Now, do you have any concerns about sending sweet Miss Ethel home? Okay, I do. I have some concerns. Um, it's a two-story house, and I told you that Miss Ethel's now having moving issues. I will tell you traditionally, in homes that are older, the bedrooms tend to be on the second floor, and your main living space tends to be living room, dining, and kitchen. It looks like at the stairwell right in this little area right over here, it looks like there's there's probably some stairs. Again, she's having issues getting up and getting down. I have some concerns about the overall structure of the home because I'm not sure that it is, sturdy enough for living. And then it looks like we have a heating source up here, and there's another heating source over here. But I don't see any additional heating sources or air conditioning sources unless they're at the back of the home. But again, I bring all this up for you to begin to contemplate and to think about how the community and the environment that a patient lives in can really affect their health. We have this thing out there right now called nutritional oases, or not oasis, nutritional deserts. And what it is that you'll typically find that in low-income neighborhoods, they have very little access to fresh foods. So in our town of Bryan College Station, I'm most familiar with that geographical location, so I'll kind of let you know, kind of speak to that. In a lot of our low-income patients live in North Bryan, so 77803, 77807, 77802 area codes. When we geographically look at that location, what we see is there is only one grocery store that sells fresh fruits and vegetables, and that's the HEB on Highway 21. If it wasn't for the establishment of that marketplace, there would be no fresh fruits and vegetables available to that community, except for the Kroger's on Boonville. That would be the closest place. We also now have the Walmart on 2018, so they kind of have them on both sides. So if you live in between Highway 6 and 2018, you have access to two grocery stores. But 2018 grocery store is a pretty significant way away from that 77803 area code. So just to get you to thinking about how environment and community can affect the patient's health. Like I said, if we want our patients to eat more fresh fruits and vegetables, okay, shop around the outside of the store, not on the inside. Very little chance of that happening if you don't have a grocery store in your area. All right, so let's talk about the next patient. This is Bob. Bob was asked on his home survey whenever we got ready to discharge him, hey Bob, do you have a home? And Bob says, yes, I have a home. Okay, but what do you see about this picture? Again, this is a stock photo off of Google. No patients have been violated here. This is a picture of Tent City, which is in Seattle, Washington. And let's say that Bob was our patient. He says that this is his home. And to him, this is home. He has shelter, he has food, he has water. When I look at this picture about environmental factors, I just want to point out how long Bob has been there. Do you see that over here, there is a wind chime, people, a wind chime, okay? That means that Bob has moved in. Do you see how here at the bottom of the tent, they've actually put in a pallet to elevate the tent, and it has a flooring. Look, an adjustable flooring right there. There's a big, huge piece of lumber. So he's got his tent off the ground to stay out of the rain, and it's elevated so that he can stay dry. So we're sending Bob home, and of course Bob will have COPD and hypertension. So what are your concerns about Bob now that you know that he's living in a tent? Let's take a quick look inside Bob's tent. When we look inside Bob's tent, again, we're seeing a lot of different things here. Do you see the types of foods that he's eating? So right down here, we can see that we're having to have potable water, okay? We do have potable water. There is some pine sol here, go Bob. But there's lots of things here. So what kind of a food could Bob store in this tent? There's no electricity, there's no water, so it's all going to have to be packaged goods. Well, one of the things that we know from our study of hypertension is that foods that are packaged are typically high in sodium. High in sodium means that you retain more water, which means that you can have high blood pressure from it. So lots of things to be thinking about, community factors, environmental factors, when we're sending our patients home. Let's move to the next slide. On this slide here, what I want to speak about is genetics. I don't know if you just haven't been watching TV in a while or what, but there are so many cool things that we're learning about genetics. In fact, the study of genetics has gone so far that now we have these commercial sites like Ancestry.com, 23andMe. They're like, please send us your samples. We've had some really cool things happen with genetics, like solving crimes, right? So cool things are happening with genetics. Well, in the process and in the world of pharmacology, that's also been happening too. We have this thing in our body called genetic polymorphism. So basically what happens is one of your little DNA kind of mutates based upon kind of like your ethnicity, which can then change a single amino acid, which then changes up some enzymes, which kind of alters its function. So what we found through this process is that there are some people out there who have, well, all of us have it, but there's a gene in your body called CYP450. And you need this gene in your liver to help you metabolize drugs. Well, what we found out based upon genetic studies was that there's some people who metabolize drugs really, really fast, and there's some people who metabolize drugs really, really, really slow. Okay, so we as providers, people, me as a family nurse practitioner, I need to recognize who I'm dealing with. You too, because this affects a lot of different things that you just wouldn't think about. For instance, in African Americans, when we try to give them blood pressure medications to control their blood pressure, it doesn't work the same. If their ethnic background is African American, it does not work the same in order to treat them for high blood pressure as it would be to treat a white lady or a white man. The same thing with Asian Americans. Asian Americans, we have to be very cautious about giving codeine medications to, because those codeine medications transform in your body basically down to the substance morphine, and it can make them really, really sick because they don't metabolize it out like they're supposed to. There's a couple of different genetic testing sites. One is called GeneSight. GeneSight is a specific test that Medicaid actually pays for in order to determine what is the absolute best antidepressant for a patient to be placed on. So you do the test, it comes back and it says the most pharmacological benefit based upon your DNA profile is going to be X, Y, or Z. And then for me as a family nurse practitioner, that tells me what to be doing. Now let's say that you say, but I'm not a nurse practitioner, Ms. Hardy, what am I supposed to do? If your patient has had this test, you're supposed to help me, doctors, PAs, to make sure that we got it right. You can look at us and say, hey, did you know that your patient had this test and this is what the results are? Because sometimes the patients will tell you guys things that they won't tell to the providers. They're trying to make the nurse practitioner, the doctor, the PA very, very happy, and they just shake their heads and say yes a lot, okay? But sometimes they'll be like, yeah, you know, I had this testing done and this is what it said, but my doctor said that I need to be on this medication, okay? Sometimes we need your help with that. GenoMind is also another testing site that to test for different levels of, like, do you have a CYP450 thing going on? Do you have others going on that we need to be made aware of so that we are prescribing you the very best medications possible? I feel like right now these databases are constantly being filled up with different like more information, because you know, the more information that we give the gene people, the more inferences that we can make based upon a population. So I feel like eventually we will get to the point to where, as long as we know kind of what your ethnicity is and your ancestry, that eventually genetic testing won't have to be as specific. It'll be more inferred, like, oh, well, you're white and you have curly hair, so that probably means you came from X, Y, or Z, therefore your most likely gene combination is going to be A, B, and C. So anyways, we'll get there. All right, next slide. Okay, gender. I know with the wide world of internet and TV and all these other crazy things that come over, that we would all like to say that it doesn't matter, male or female, let's just all get along and be happy. And I agree. However, there was a saying that my mama used to say, and my mama used to say this. She used to say, Jamie, it's really on the inside that counts, that matters the most. She's absolutely right when it comes to medications. The chemical composition on the inside of a person, whether it be male or female, is critically important for us to understand as providers of healthcare. You, me, all of us, we have to know, are we dealing with female organs or are we dealing with male organs on the inside? It's what's on the inside that counts, okay? So yes, it makes a difference. If you have ovaries and you are a female, your genetic composition is completely different than that of a man. So when we're going through this and we're giving out medications, it may not be that the medicine that you need to be prescribed is appropriate for you based upon what's on the inside. Okay, so the other great news I'll tell you for us ladies out there, typically the FDA in the past never did testing, any kind of new drug testing on females. It was always highly controversial because we were childbearing age. And then what would happen if they gave us a medication that they were drug trialing and it affected your ovaries and then affected your ability to be able to conceive later on. So it didn't really do it. So what they're doing now is that they're actually allowing females into drug trials, which is amazing. Excuse me. So we'll kind of have a better understanding of what drugs actually work best on us as we go through. Guys, there's nothing that the sand and the salt can't fix. And thank you guys for listening, and we'll see you guys on the flip side.